Okay, speed dating part 2. So let's all shift our cognitive set a little if we can, and we're going to look at eating disorders for the next 10 minutes. So first, I just wanted to start with some UK data which might be helpful for you to put eating disorders into context. In the UK, we know that on a typical GP caseload, there are approximately 1 to 2 patients with anorexia nervosa, about 18 patients with bulimia nervosa. About 5 to 10% of the adolescent girls that you're seeing will be engaging in eating disorder behaviours over and above dieting, not just dieting, but perhaps purging, excessive exercise, diet pills, etc. And as those young girls grow older, when we get to more the university population, we see that 1 in 3 young women in a first-year cohort, this is New Zealand data, are scoring above the cutoff for disordered eating measures. So this is not something that is rare, and I'm sure you probably know this already, but this is definitely something that we want to keep our eyes out for. That gender ratio there as well, 10 to 1, let's not forget about the 1. Quite often males are misdiagnosed with anorexia nervosa, and it's just something that we really want to be sure we're not losing when we're thinking about what is troubling the young person sat in front of us. Okay, so a brief overview of DSM-5 categories. We've gone from 3 official eating disorders to 5 standalone, if you will, eating disorder categories in DSM-5. Anorexia nervosa looks largely the same, although criteria D, which was the amenorrhea criteria, has now been dropped. Bulimia nervosa, again, looks much the same in terms of diagnostic criteria. However, the frequency required for diagnosis, which was twice a week for at least 3 months, is now dropped to at least once a week for 3 months. This is largely because a lot of bulimia nervosa presentations were falling into our not otherwise specified category. Therefore, that wasn't being very helpful for treatment planning. We have binge eating disorder now. This has binging in the absence of ICBs or inappropriate compensatory behaviours. So where bulimia has binging plus purging, binge eating disorder has binging but no purging. Okay, so understandably in this group we see much higher BMIs, typically in that high normal BMI or even the overweight and obese end of BMIs. And then we have ARFID, or avoidant and restrictive food intake disorder. And I want to spend just a little more time talking about this because this is something that is quite new. It may not be quite on your radar yet. So ARFID typically presents in children and adolescents. It is a lack of interest in eating food, or it is an avoidance based on sensory aspects of food, such as only eating smooth foods, or it's a concern about aversive consequences of eating. So for example, I can't eat that, I'm going to choke. And then the food repertoire gets smaller and smaller and smaller. So as a result of this, we see significant failure to meet the nutrition or the energy requirements, or we see a failure to achieve the weight gains you would expect for that young person. We have significant nutritional deficiencies, a lot of anemia, a lot of fatigue, and then we have marked interference with psychosocial functioning. So oftentimes these young people aren't eating at school, so lunchtimes they're feeling left out, they're feeling a bit different. And all of those family-based things that we're doing around food and eating are disrupted because of these eating behaviours. Now, quite different to anorexia and bulimia nervosa, in ARFID we do not see the body image concerns that we see with other eating disorders. This is about the food, this is not about weight and shape. So moving to assessment and investigations, and this is in the context of primary care. Obviously, you're going to want to look at what is presenting in this young person. Is there restriction, meal skipping, binging, fluid intake? A good little way to get an understanding of the cognition that's going on for them and how ingrained that is to ask, do they have any kind of sense of, I'm allowed this food and I'm not allowed that food, or this is a good food and this is a bad food, okay? If you've got some significant kind of almost rule-like behaviour happening there, then that's a good clue that this is something you really want to get onto. So trying to suss out a little bit around body image distortion, any kind of signs of early satiety, exercise patterns, very important to look at what they are, and then those purging type behaviours as well. So in blue here, I really just want to highlight what we need to be aware of, particularly in young people when we're assessing these types of things. What we don't want to do is do any kind of prompting or seeding of ideas. Okay, so these young people are often very susceptible to thinking, oh, I haven't actually thought about purging, or I haven't actually thought about diet pills, I might go away and do that, okay? There's actually a whole base of prevention studies that were done in the early 2000s, where following the typical model, we thought, let's educate, do lots of psycho-ed about the negative effects of eating disorders with young women, with I think it was about 12, 13-year-olds, and that will act as a nice early prevention strategy. It did not. They all got worse in their eating disorder symptomatology, okay? So we need to be really aware that we're holding this very lightly with them. For example, I often ask here, sometimes along with these types of behaviours that you're describing, for example, maybe you've just talked about binging, sometimes people do feel the need to do things after that to make up for what's just happened. Is that the case for you at all? And just trying to leave it open and see what they come back with. If you have suspicions, obviously you can go a little further with that, but again, just being really mindful that we're not seeding anything. Always gather information from other sources, particularly for adolescent anorexia type presentations. When you've seen some dramatic weight loss, don't just take the young person's report as your only report, essentially. So there's a lot of symptom minimisation in this group particularly. There is a lot of lack of insight, really. So we want to be sure that we're getting the right information here. Okay, ask the parent their report as well. It's not uncommon that you'll have a young person in the early stages of anorexia nervosa present to primary care, and the story will be, oh no, it's fine, I'm just being really fit. Oh no, it's fine, I'm just getting really healthy with my eating. Okay, that may be the case for some, but it may also be that something else is going on. We want to know what other people are observing as well. And then also considering your comorbidities, particularly risk. So medically, you're going to want to look at obviously your weight, height, BMI markers, things like seated standing pulse, seated standing blood pressure, temperature, and then blood chemistry as well. Really, really helpful if you are referring that you can include as much of this information as possible. So on assessment, I just want to highlight the SCOFF questionnaire for you. This is very easily found on Google. Just put SCOFF questionnaire, it'll come straight up. 5 questions that are really going to help you orient in your assumedly 15-minute consultation to try and gather some information from this young person. So the rule of thumb here is if you are getting a yes response for 2 or more of these questions, then that's probably indicative of a clinical eating disorder. On the same lines, I highly recommend this 5-page-ish document that's been put out by the Maudsley Hospital in London, the GP's Guide to Eating Disorders. A lot of what I'm talking about today is taken from that. Really good resource covering the base of what's useful for a general practitioner. So managing anorexia as a GP. So therapeutic relationship is very important here, okay? We want to focus on establishing nutritional health through eating and managing the risk of malnutrition. Not as easily done as it is said in this particular bullet point, okay? We want to involve the family in care, and particularly for adolescents, family is crucial here. They can be massive advocates and massive pieces of really driving forces behind change here. So definitely be looking to involve the family. And I would suggest, maybe not everybody would agree with me, but I would suggest that if you're pretty confident you've got a case of anorexia nervosa, it's going to be rare that that's going to be appropriate to hold just in primary care. You're probably going to want to be referring that on for specialist treatment. In my capacity in private practice as a clinical psychologist, I liaise quite a lot with GPs, and how that often looks in terms of treatment is that the GP is doing either weekly or then dropping to fortnightly, monthly medical monitoring alongside weekly psychological sessions and dietetic sessions as well. Okay, so a bit different for managing the binging type presentations. The focus here straight out the gate is on regular eating. And the reason for that is that eating patterns get massively disrupted, and therefore the binge risk goes up. So we want to step that down, and we want to focus on regular eating to reduce the chance of the binge eating happening. Okay. Another thing that is a helpful thing to do if you have time for doing it is to plan with them specifically. After a meal, what will you do? What's something that will distract you? What's something that you can plan? Can you phone a friend? Can you go outside for a walk? Okay, these types of things to get them out of the environment where the purging might be happening as well. If you have somebody with a binging type presentation that has high motivation and that has a mild presentation, then this can probably be managed in primary care. And we've got some really good evidence from treatment trials, and again, this is particularly for young people, that we can predict quite reliably from the first 6 weeks of treatment how things are going to go. Okay, so if you're not seeing significant change in that 4 to 6 week period, then I would suggest you want to consider referring. Okay, and then shifting to ARFID. So you want to work, again, as mentioned earlier, with the child and adolescent and with their significant family members. You want to have a thorough assessment and understanding of what their food intake is. This may or may not be possible in your setting. You may need to refer for dietetic, specialist dietetic here. But the general treatment approach is to gradually build up that food repertoire, working with the young person and what they can manage. Okay, often these families, they're stuck in, well, they won't have what they're served for dinner, so they're not having any dinner. Okay, so we need to actually do that through graded exposure. What can they manage? Send them away with a couple of things, come back, build on successes. Again, use that 4 to 6 week marker. If there is significant interference for this young person, then you really want to get onto this promptly. Same goes for any kind of adolescent eating disorder. Okay, so what specialist interventions are there? In terms of child and adolescents, if you are referred, for example, if you're referring your patient to the Regional Eating Disorder Service, tupu ora, then they're most likely going to be offered family-based treatment or FBT. And then just for your context, in terms of adult anorexia and bulimia nervosa, we have really good evidence for a modified version of CBT called CBT-E, or enhanced CBT-E for eating disorders, that works really well in outpatients. Okay, that's a 20-session protocol. For adults, anorexia, we don't have standout evidence for that, other than we know that specialist input here is preferable over generic. Okay, so what is available in the Auckland setting? So we have the ADHB service, which houses tupu ora, which is our regional eating disorder service. They have an outpatient service for both child and adolescent and adult. They also have a day program, which has space for between 8 to 10 people. They have a residential program, which is 24/7, and that has, I believe, 8 beds. And then there are also some starship beds for young people that require hospitalisation. In terms of private services, there are 2 specialist outpatient services, Shelley Beach Practice and NZEDC, and I can't recommend highly enough to have on your radar EDANS, the Eating Disorders Association of New Zealand. They do fantastic support work for families. They're a free service. They run a telephone helpline. They have a fantastic website. Really great place to orient your families to. And just finally here, if you have an interest in any further kind of training in mental health, there are 2 papers that I run here at Tamaki campus. Semester 1, we have an adult primary mental health paper that has a block course on CBT skills for the 15-minute consult. And then semester 2 is the child and adolescent mental health for primary care paper. Okay, thank you for your attention.